Welcome to today's episode of Medically Speaking. I'm super excited to have a great guest with us today. We have Dr. Ellur with us today from our behavioral health team. And today we're going to talk about mental illness and some treatments and opportunities that we have in our community to improve some of the care and some of the latest treatment modalities that are available. We're going to touch on some of the inpatient treatment options as well as outpatient treatment options and just mental health in general. Interestingly, the month of May is Mental Health Awareness Month, so I think the timing is just about right. So with that, I'd like to maybe introduce Dr. Ellur and welcome him to the podcast. And Dr. Ellur, maybe just tell us a little bit about yourself and your background.
Yeah, thank you, Dr. Logan, for giving me this opportunity to speak to in this podcast. So, I'm Dr. Ellur. I joined Self Regional Health in October last year as a staff psychiatrist and a medical director for the psychiatric services. So, since then I'm excited to be here. Looking forward for our vision of high quality, accessible care in this regional health system, and which is serving the 7-county area. So,
awesome. Yeah. Well, thank you. So we have really seen growth, I guess, in mental health illness, and not something the kind of growth you necessarily want to have, but we certainly want to be here to help folks. And maybe you can tell me a little bit about some of the services that we offer at Self Regional, just in general, and some of your experiences here so far.
Yes, a little bit about my background is I born and raised in India and went to medical school in South India, and after that I was trained in Thomas Jefferson University in Philadelphia, Pennsylvania. Then spent significant amount of time in the rural Missouri for 7 years, completing the Delta waiver programs and see, what type of the services there is a community need for those kind of behavioral health services, and how to improve the services, how to engage in the community stakeholders and bringing the highly accessible care to the rural area. So with that, our Self-Regional Health as both inpatient and outpatient services. Inpatient currently has 36 bedded, in the currently admitting age group of 18 to 65 for the patients suffering from depression with suicidal thoughts, schizophrenia and other related psychosis, bipolar disorders, dual diagnosis, and patients who are just feeling unsafe at home and having the underlying mental health diagnoses. These are the common admitting diagnosis and admitting problems on our inpatient at Self-Regional Health. So, and in the outpatient, we are treating the patients with the depression, anxiety, comorbid substance use disorders, PTSD and other trauma-related disorders, and bipolar disorders, even schizophrenia. We just now added addiction medicine as a co-located and collaborative care model into that, and to bringing whole spectrum of services to our outpatient at Western Carolina Psychiatric Services.
Okay. Well, let's talk about the inpatient side, maybe a little more detail, then we can dive into the outpatient world a little bit more too. So, what's the typical path if someone does have a mental illness and they need to be admitted to an inpatient psychiatric unit? How is that decision made, and what's the usual process to get plugged into the system?
When the patient has severe depression or not able to significant impairment in their activities of daily living, it could be social functioning in terms of relationships, or if they're students, they are struggling with academics due to academic stressors, or if they are working in some kind of job here, they're struggling at the job. So these kind of significant impairment with underlying depression, if they continue to have thoughts of self-harm or suicidal thoughts, then that's the reason for to visiting our emergency room. And we have a trained behavioral health assessment team. We go by BHAT. They are essentially a mental health screeners. They are the conduit between the emergency physicians and the inpatient psychiatrist who provide the care, they go and evaluate, they assess the need and the level of care they need in terms of medication management or inpatient level of care or even outpatient level of care. They discuss with the on-call psychiatrist who is an MD or DO and come up with a plan for them, either admitting or discharging or even transferring if we are not able to provide any care at the inpatient level. So, and the another condition is, first is depression, second is severe psychosis, having various types of perceptual disturbances, the auditory and visual hallucinations, various delusions, and even agitations. From the agitations, irritability, from the underlying mental illness, and bipolar disorders are the indications for admissions to the inpatient unit.
Yeah, so I know I'm an ER physician too, in my background working in the ER and taking care of mental illness problems over the years. I have seen a lot of improvement, I think, in some of the services that we offer on the inpatient side. And I think you just hit on it. That behavioral health assessment team, that BHAT team, they are really key to the whole process. As a ER physician, I'm really good at identifying medical issues and really kind of ruling some things out. But once you've kind of ruled out those like medical reasons for the way someone's thought processes may be going on, it's awesome to be able to have the resources here in our local community to kind of take that next step if we need to, say, be admitted for further inpatient treatment.
Absolutely. So when in the medical primary, if there is any underlying medical disorders or neurological disorders are involved, our emergency room physicians are excellent, and they're very good in what they do in clearing them and finding the way to get them this type of care and the level of care they need. As I said, our vision continues to be the same high quality, accessible care in our regional health system and
Yeah.
our the 7-county service area. So
Yeah, absolutely. So yeah, kind of rule out the medical non-mental health issues, and once those are kind of ruled out, then the behavioral health assessment team and you and your expertise kind of identify kind of next steps for those individual patients. So I really like that model, and I think it seems to be working pretty well for us here. So, all right. So let's say that someone does have, like, say, let's just use an example, severe depression, and they're thinking of harming themselves. Like, what's the process? And, like, how long does someone usually stay in the hospital, and what happens in the hospital when they're there?
I'm glad we are having these conversations. As you already said, the May is the Mental Health Awareness Week, and the CDC and SAMHSA, with the multiple efforts in the past, like 5 years ago, they created 988 suicide prevention hotline or suicide and life crisis hotline, where the patients themselves can call the 911. It's a private and confidential conversations to express what they're feeling inside and connect with the resources and telling them to guide them in the process. And the family members can also call to guide them and to provide them with the resources and telling even connecting them with the 911 calls has been very helpful. It created somewhat dent in the suicide rates nationally and also in the state of South Carolina too. And when they come in, there is a thorough assessment for suicide risk and safety assessment that they receive. They receive PHQ, Patient Health Questionnaire, 9 questionnaire in the ER, and also Columbia Suicide Severity Scale also the provided to them, and the BHAT team, the evaluates, ED physician does that as well. There are multiple eyes and multiple hands who are involved in the care when the patient comes to the ER.
Mm-hmm. Okay, so let's say the patient gets admitted to the hospital, and for, let's just say, severe depression, like what's the treatment that they get while they're in the hospital?
So traditionally, the treatment has been for years the medication management. Then came like antidepressants, like SSRIs, which act on the serotonin receptors, and norepinephrines, SNRIs, and atypical antidepressants like bupropion and Remeron, and medication has been the mainstay. And again, to supplement that in kind of like a severe cases of major depression is psychotherapy and medication management combined are very helpful, like cognitive behavioral therapy and interpersonal therapy and supportive psychotherapy and a little bit more advanced psychotherapy like psychodynamic psychotherapy would be very helpful. But usually when they get admitted to inpatient floor with this, when they're danger to themselves or others, and they receive thorough psychiatric evaluation, and we have groups, we have individual therapy and recreational activities, where they learn the coping skills and relaxation techniques. They get a full comprehensive services when they are on the inpatient floor. And the psychiatrists visit with them every day round and assess the need. They work with the social worker on the unit, identify and provide the resources for them when they are stable and ready to be discharged. So
That's great. Okay, so let's say that same patient now is ready to go home and they are no longer thought to be a threat to themselves or not want to hurt themselves anymore. But the treatment doesn't necessarily end at that point, right? Because things, as we all know, life stresses can come back, or whatever that was that kind of may have triggered that episode may still be out there, right? So what happens when the patient leaves? Like, what are the resources that patients can follow up with when they leave the hospital?
So I work closely with our unit social workers, who reach out to our community mental health resources like Beckman Mental Health and our Western Carolina Psychiatric Associates, and we find a therapist, a counselor with the LPC level, and also the psychiatrist or psychiatric providers to continue the psychotropic medication management and continue the psychotherapy for them wherever they are, depending upon their zip code or the counties where they live in. Try to connect with them and make the appointment date before they leave, and make sure the family is also on board with this, or they are aware of the discharge plans and aftercare plan.
So it's really on the outpatient setting, well, inpatient too, for that matter, it's a combination of like sometimes medications to help kind of stabilize the brain chemistry. We can think of it that way, and then as well as counseling and following up with a mental health specialist like the psychiatrist and/or counselors and whatnot in the outpatient to try to deal with those ongoing stressors in a way that's more healthy. Maybe
That's
we could
correct.
say that way.
Yeah.
Because there's always going to be life stress, right?
Yes,
It's something
absolutely.
all the time.
Improving, the identifying each when they are in the inpatient unit, psychiatric inpatient unit, we have a team, interdisciplinary team, I would say, or multidisciplinary team, because you have a recreation therapist, we have a psychiatric social worker, psychiatric nurse, psychiatrist, and we have the other therapist as well. So we have the bonus is like we also have the clinical pharmacist who is trained in psychopharmacology. It's very, very rare to have a clinical psychopharmacologist who did a residency and helping us out with and explaining the family and the patient about adherence to medications and about the medications prescribed, how do you take them, where do you get them, arranging the medications. It's a very comprehensive multidisciplinary team. We all visit with the patients every Wednesday, and we make the treatment very individualized. Again, every patient has a different needs because their backgrounds are different, or they grew up in a different types of families, with or without trauma. So when we make the treatment, we ask them to state what are the two important things you would like to work on and you would like to continue to work on after discharge. So then they come up and they learn the coping skills, and we'll make the treatment plan suitable for that patient, so individualized. And the same one, when they are leaving, we find the similar therapist and a psychiatrist so that they can continue their care. So preventing here, you're also thinking a bigger picture is you are preventing suicide. The patient came here for help, and we are providing their psychiatric evaluation. You assess the safety and risk, and you address, what is driving what is driving them to experience these kind of thoughts, and then you're mitigating the risk. Then they continue the care outpatient. So.
Yeah, no, that's great. Another thing that comes to mind that is challenging is there's a lot of situations where someone has some type of mental illness, whether it be depression or some type of chronic psychotic disease or something like schizophrenia or something else, and then they folks try to help themselves a lot, and a lot of times people end up getting on substances of some sort, whether it be like using excessive alcohol or perhaps drugs, marijuana, who knows, all types of different medications that people, or I say illegal drugs, we'll say it that way, that people can get on and kind of end up with that dual diagnosis where you've got like a mental illness and also a substance use problem. How do we address that situation?
Yeah, that is very important. This is one of the identified community mental health needs. So we are about to mark on the second 2024 community health needs assessment from the South region. So according to the 2022 report, our needs is still like patients who are suffering from dual diagnosis, primary mental health, secondary substance use disorders, and who has solely just without any mental health, we have substance use disorders. Prevalent one is opioid use disorders, stimulant use disorders like cocaine use disorders, alcohol use disorder is a big one again. So when they come in, we assess first thorough psychiatric evaluation, getting a detail the history of their drinking, detail a history of the underlying the past psychiatric disorders like a depression or schizophrenia or bipolar disorder or anxiety or panic disorders, and starting the medication first in the medication first model, where you also treat the primary mental health with the psychotropics like antidepressant, anti-anxiety, or mood stabilizer, depending upon their primary mental health diagnosis, and the secondary substance use disorders like we have naltrexone for alcohol, we have gabapentin, we have topiramate, we have disulfiram. That model has also helped us to treat both mental health and the secondary substance use disorders as well. And they also go into crisis, just like patients who do not have the substance use disorders. The plain mental health, I would say, is pretty hard because there are like 40 to 60% of the mental health disorders are comorbid with substance use disorders. It's very difficult to tease out, okay, this which came first, and there is that's the reason why we have to make sure that all the dual diagnosis is treated and mental health is treated, and when they are stable and ready to be discharged, again, individualized treatment plans. They go to substance use follow-up, where we have in town is Greenwood Cornerstone and Abbeville Cornerstone, and for the residents living in there, where the intensive outpatient program for drug and alcohol referral we provide the psychotropic medication support, and they can go to attend the groups there in the intensive outpatient 3 times a week, 3 days a week, and they interact with the therapist and counselor there. So you are taking a full comprehensive approach for the recovery. It's not just treating mental illness and discharging them. You're addressing all the issues. So it's been working, and because this is a huge need in the community. So.
Yeah, absolutely. We just, our South-Regional just received a nice grant from the state to start a medication-assisted treatment for opiate abuse disorder.
Yeah.
And maybe you could talk about that unit a little bit and kind of what some of the goals of that area are.
This is exactly the right time again. So the grant for the medical stabilization unit and the continuity of care in terms of partial hospital program or intensive outpatient program for the patients with the substance use disorder, mainly opioid use disorder, because this is continue to be one of the cause, and which is driving the increased rates of national suicide. Again, South Carolina ranks 29th in the state for the suicide rates, deaths by suicide, and it's still like the number of suicide deaths are like 1 percentage point higher than the national average still. Our neighboring Georgia is a little bit less, but we continue to, again, this is a public health problem. Suicide is a public health problem. So the illicit opiates and even the prescription opiates, they continue to drive these rates of suicide. So when you look at the rates of suicide nationally, they're increased a little bit. I would say not very significant, but they're increased. Now, CDC, they started, and SAMHSA reviewing what exactly happened. We are coming out of COVID the last 3 years and increased access to these prescription and illicit opiates like fentanyl. So that was the reason why it really made a sense to start this medical stabilization unit at Self Regional. And when they are stable or when they started on buprenorphine, which is a standard of care for opioid use disorders, you initiate the buprenorphine induction. And when they are stable within 3 to 4 days, you find the right dose of buprenorphine, which is an opioid antagonist combination. So we transition them to outpatient level of care. That's the reason why we have onboarded Dr. Amber Gaspard. She's very interested in addiction medicine. She's been doing that, and we're transferring the patients there, so they're receiving the care for the opioid use disorder.
Yeah. I think that's a neat program that I think is going to grow with a little bit of time as more folks learn about it. But the ability to kind of come in and get detoxed in a way is kind of, I think, how maybe the community might think about it. I'm going to go through, so you don't go through such severe opiate withdrawal, which can be very severe, not necessarily life-threatening, but you feel terrible when folks are going through that, and a way to kind of get off the opiates. For folks that are ready to make that change in their life and want to get back on track, to come in the hospital, a couple days intense treatment, and then transition to the outpatient setting. I think it's a really neat model. I'm pretty excited about being able to offer that.
I think
here.
it started working, and we started in early March, and the patients are started coming in, and we're getting the referrals from outside sources and within the hospital, in-house. It's just the awareness, again, the community awareness is so important in this recovery of these patients and reducing the deaths from the illicit opioids and also prescription opioids so much. So
Absolutely. So let's touch on, just for a second, like other community resources. Of course, Self-Regional, we have outpatient treatments and inpatient hospital stuff, but what are some of the other community resources that our patients can tap into?
So we have Beckman Mental Health. They have from the state Department of Mental Health sponsored and contracted the agencies. They also treat this they've been very helpful with the severely mentally ill. They don't have acute facility. They do have outpatient. They provide the medication management, and they provide the counseling services and psychotherapy, and they do provide the DBT, dialectical behavioral therapy, the standard of care for patients with borderline personality disorder in the region. So that has been helpful. They have the multiple locations to the county areas which are our service area. So in this, they can able to connect with their individual psychotherapist. And they have provided the telephone consultation. They have the DBT groups, and that is one thing. The second is we have the Greenwood Cornerstone Drug and Alcohol intensive outpatient program, where there are groups, 3 times a week, 3 days a week. So that are also helpful in this community. So with that, each county has their own, just like Beckman, they have the Abbeville Mental Health, for the residents of Abbeville County. For Newberry and Edgefield, they have Edgefield County Mental Health, and so there is a Westview Behavioral Health for the patients in Newberry and other side near the Lexington. So, which is nice, you trying to improve the access. The goal here is to improve the access to mental health services, which can reduce the suicide rate. Again, why the South Carolina is on 29th in the suicide rates, and is because there is a 74% less access or mental health provider in the state of South Carolina. So, and again, in terms of behavioral health expenditure, is still we are on the 25th percentile. So, what the state has spent in terms of invested in behavioral health is less than 25th in the state. So, that's again there is always a need for the inpatient, the patient looking for the bed for the inpatient level of care. There is always a patient who is waiting for an appointment to see a licensed or qualified psychiatrist and a psychiatric providers in the state. So
Absolutely. So there have been some advances in some of the treatment for outpatient depression. I thought maybe we could just touch on those for just 1 second. Let's talk a little bit about, I guess, treatment for depression and some of the newer treatment options for severe depression on the outpatient side.
yeah. So historical perspective in the treatment of depression is very important. So when we, the DSM, the Diagnostical and Statistical Manual, now in the edition 5, the text version, all the device, they have gone through a lot of formulation because of the emerging research and the evidence they have gathered. There are a lot of, we never used to call the alcohol use disorder, used as alcohol dependence. Cocaine used, cocaine dependence. And those words are gone. There is a change in the language, obviously, because of the evidence and the research has indicated. And so that also, in an attempt to destigmatize, lessen the stigma and improve the awareness and bring them to the care. And you're also following the harm reduction model in treating this addiction. So in our outpatient, traditionally we have treated with the antidepressants, like SSRIs and SNRIs. We have atypical antidepressants. I use antipsychotics, mood stabilizer like lithium, Depakote, and other augmentation strategies. So when there's increasingly, there is a nearly at least 1/3 of the patients, they don't respond to antidepressant. It's surprising when 2 or more antidepressants, they don't work as they should. Wow. When they fail to respond to the antidepressant, so they started, the psychiatrist started looking at other interventional modalities for the treatment of depression and other depressive disorders. So there was an ECT, electroconvulsive therapy, and it's not available at South Regional. It's available in Greenville, Columbia. So now we have for the first time in 2019, they found out ketamine has been, the evidence showed the ketamine is helpful in depression, especially those with the treatment-resistant depression. We call it as TRD, when they fail to respond to or more types of antidepressants. Then they are maybe they can benefit from the ketamine treatment. Again, the ketamine sounds like it's a very counterintuitive, because it used to be a special K. It has a street value. It used to be a street drug. It is closely related to PCP, phencyclidine, and the ketamine is already used in our operating rooms as a dissociative anesthetic, and they found out that our increasing understanding based on the research that it is not only serotonin, norepinephrine, GABA, and the dopamine. It's also there is 4th receptors there in the brain, which is altering and causing neuroplasticity changes in the brain and affecting our learning and our experiences, and try to improve the depressive symptoms. That was the glutamate. So ketamine is a NMDA receptor antagonist. It's a blocker and improves the glutaminergic neurotransmission in the brain. It is another 4th pathway for the depression. We started exploring. Our understanding in the depression has gotten much, much better, especially in the last 20 years. So the more so with the last 10 years, when they had 3 or 4 randomized control studies, found that ketamine and S-ketamine, its derivative, is very helpful in changing the brain chemistry and neurocircuitry to improve the depressive symptoms, those with the acute symptoms and those with the treatment-resistant depression. As 2 or more antidepressant fail to respond, so then is option. The patients do stop take the medications because they have the side effects. They just don't tolerate. So now comes the ketamine. It's one of the there are centers in the nation where they receive the IV ketamine infusion. We call it treatment KTCs, ketamine treatment centers, and There is also use of ketamine in ketamine-assisted psychotherapy, just like the mushrooms, psilocybin-assisted psychotherapy, LSD, the hallucinogen-assisted psychotherapies. So much understanding in terms of psychedelics. Just like that, the S-ketamine also has been FDA approved for treatment-resistant depression and treatment-resistant, the major depression with suicidal ideation. The two indications for S-ketamine. One is treatment-resistant depression. The second is major depression with suicidal ideation and behaviors. So,
Gotcha. So, yeah, just I'm just going to summarize that up in I think a simple way to think about it. So, if someone has like they've been on some antidepressants and they're still suffering with depression and they feel like it's not getting better, or they can't tolerate it very well, and they've tried a couple different ones, so it's just not getting better despite treatment. Or if someone has severe depression with suicidal thoughts, and then they would potentially be a candidate for the S-ketamine or the Spravato treatment.
Yes,
Is that
that's correct.
basically kind of the
That's
idea?
correct.
And it works in the brain a little bit differently than some of the other antidepressants that are currently available, and can sometimes help when other things don't,
Yes.
essentially. And then, so the Spravato treatment, tell me a little bit specifically about Spravato, like how do we administer it, and like how often do you have to take it, and all those type things?
The S-ketamine, or the Spravato, the commercial name, is approved for both with and without antidepressant combination therapy in conjunction with antidepressant. But in January this year, they approved as a standalone treatment for treatment-resistant depression, which is nice. So you have this treatment-resistant depression, you don't need to be, or the major depression where you have the suicidal thoughts, you can use it as a standalone. It is for first time the FDA has approved as a single standalone treatment, without any other medications.
Okay.
But when you refer to treatment-resistant depression, there are like prior trials of 2 or more antidepressant, and then you define the treatment-resistant depression.
Okay.
It comes in as a nasal spray. It's just like our Flonase.
Okay.
It's kind of each spray is one dose.
Okay.
This is just like our Flonase
Yeah.
nasal
Yeah.
inhaler. It contains 28 milligrams of ketamine.
Okay.
So it is only administered at the very licensed facility and credentialed under the, which is REMS certified. REMS is risk evaluation and mitigation strategy. So all the facilities like medical offices, psychiatric outpatients, or even the inpatients, so they have to be certified by REMS. So it is a process wherein you identify the risk, and you are able to mitigate them, identify the risk and mitigate those in terms of like elevated blood pressure, the dissociation, the patient tend to disconnect from the surroundings, and then sedation and elevated blood pressures. You should be able to manage, but with Western Carolina Center, with the staff education, and we are in the process of getting the Western Carolina Psychiatric Associates enrolled into this program so that we can start these services. We are already in the process
Yeah.
of starting this treatment.
Yeah, great. So we're in the process of getting approval to administer the Spravato, the S-ketamine treatment, in our outpatient Western Carolina Psychiatric offices, our office, sometime soon. Any idea when we anticipate like getting through that approval process?
Our hope is that as early as early June, the first week of June,
Great.
we should be ready to. This should be available
Good.
for the patient to access. Again, the patient selection, which patient is going to benefit, is the key for the better outcomes or the good outcomes. So, who has not responded to those antidepressant, and this 4-week treatment? This is a twice weekly inhalations, nasal spray. They check in, and you have a space for the monitoring. And after they administer, they have to be in the office for 2 hours. There's a space. They monitor at the end of 40 minutes. They check the blood pressure, make sure that blood pressure is not elevated, and evaluated by the provider before they are ready to go home. We advise caution against driving and operating machinery because of the mild cognitive impairment and sedation that comes with this dose administration. So the initiation phase is for first 4 weeks. twice a week in the clinic, 2 hours monitored for the blood pressure and sedation and dissociation, and we have the family member pick them up and go home.
So twice a week for 4 weeks.
4 weeks is the
And
initiation
then, like,
phase.
how long does it work? Like,
It has, you see the results as early as first 24 hours relief from the depression.
Wow.
How it changes the glutamate, the neurocircuitry in the brain. You get 24 hours, and you see more effect by end of 4th week.
okay.
So again, if the psychiatrist after evaluation thinks that the patient needed to enter the maintenance phase and the continuing on the ketamine spray, they can. Again, that would be tapered along once weekly to once to 2 weekly or bi-weekly spray, and it's just one dose, 2 nostrils. You close one nostril when the patient is using the other nostril. So the 2 doses each visit with 56 milligrams of ketamine should help the relief from the depression. Mm-hmm. This is very important because they have been struggling going through one of the treatment challenges we have in the outpatient treatment of depression is trial and error. You try this, even though it is guided by precision medicine now with the genetic testing, where we take a buccal swab and send them to testing for the their DNA and type how the medication interacts, but still they are just guiding, but they don't replace the psychiatrist, the decision making process. So this one is one of the tool available, and this is a new medication, and I have to be very careful at the same time. Is a class 3 scheduled controlled medication. Mm-hmm. That's why the facility or the medical offices or the outpatient need to be REMS certified.
Right. So again, help me with this. So someone gets treated, you say it's twice a week for 4 weeks, and then they go, if they're doing well, onto a maintenance phase. Is that something you have to take the rest of your life, or once a week the rest of your life, or is it, how does that transition?
There is no studies with the long-term use.
Okay.
Again, we are treating the treatment-resistant depression, or you're treating the major depression with suicidal thoughts. So for the treatment-resistant depression, there are some studies, some evidence to beyond 4 weeks they can benefit. Again, the psychiatrist evaluate the patient. Again, each and every patient is different. There are no guidelines of continuation beyond the initiation phase. Mm-hmm. But weak evidence, but there's some evidence with the treatment-resistant depression, but not with the major depressive disorder with suicidal thoughts. First 4 weeks, at the end of the 4 week is you see the maximum benefit in terms of the relief from the depression. This is acute relief. One of the analogy I remember is in a patient who presents with the asthma, acute asthmatic attack, and you give the albuterol spray, mm-hmm. and then they get relief from the wheezing, mm-hmm. and they start breathing better. It's a similar thing. Patient enters the emergency room they're in crisis, having the suicidal thoughts, having this access to ketamine is a relief from the suicidal thoughts. It's amazing how the ketamine works on the brain neurocircuitry to relieve those suicidal thoughts is still unknown, but it has a rapid resolution of symptoms is one of the key word I would like to use in terms of both depressive symptoms and the suicidal thoughts.
Yeah. Well, we're excited to be able to offer that here real soon. Anything you want to close with, or our listeners, anything you want to share with the community about any of our services, or really anything about mental health at all?
We are accepting new patients, for the Western Carolina Psychiatric Associates with this addition of Spravato and REMS certified, and we are accepting the patients with the depression, trauma, children's, and adolescents. And in the inpatient wise, we are treating the patients with a dual diagnosis and the mental health conditions that I had mentioned earlier in the talk. So, and we are looking forward for the other new modalities of the treatment, like transcranial magnetic stimulation. Yeah. So we're just taking one day at a time. Yeah. And it's really exciting to be here in this community. Yeah. And our goal is high quality, accessible care in the region.
Yeah. So, Dr. Ellur, thank you so much for spending some time with me today. And we're certainly glad you're here, and we appreciate your leadership and helping us really develop our behavioral health services for the community. So thank you so much.
Thank you, Dr.
And
Logan.
thank you all for joining us for today's Medically Speaking, and we'll see you next time. Thank you.